I'll be presenting the first case in our renew teaching conference, now entitled Case Records of the Mayo Clinic Florida Neurosurgery. It will be the first case, and the presentation is entitled The Autoimmune Trigger. This is a case from Dr. Alfredo Quiñones. So first of all, we would like to thank the multidisciplinary team involved in the care of this patient, including Dr. Quiñones in neurosurgery, Dr. Marin Collazo in neurology, Dr. Stephen Rosenfeld in neuro-oncology, Dr. Agarwal in neuroradiology, and Dr. Mark Chentov in pathology. So this case is about a 50-year-old woman with a chief complaint of right leg paresthesias and dysesthesias in the year 2020. She underwent a thorough neurological evaluation at an outside institution. EMG was shown as normal, and the CSF analysis shown 4 unique oligoclonal bands with evidence, of course, of inflammation. This prompted a recommendation of an MRI scan at that moment. Past medical history was relevant for hypertension, palindromic rheumatism, which had been treated by methotrexate, hypothyroidism, and vitamin B12 deficiency. Family history was relevant for Hashimoto's thyroiditis and palindromic rheumatism, both of them in her mother. And on physical examination, her head was normocephalic and atraumatic, cranial nerves were grossly intact. On lower extremity examination, there was decreased pinprick sensation, and reflexes were 1+ throughout. So here's the MRI taken in February 2020. First, we have the sagittal T2 thoracic spinal cord MRI, where we can see a hyper-intense lesion located at the T10 level. And we also got the brain MRI in an axial view. Here we have that T2 view, where actually there was no evidence of any tumor or any inflammation that we could tell at that moment. So with these findings at an outside institution, the patient was diagnosed with transverse myelitis, and she was treated with 3 days of IV methylprednisolone. The patient referred that at that moment she didn't experience any significant improvement. So she was further evaluated for more autoimmune disorders, including optic neuritis, internuclear ophthalmoplegia, and multiple sclerosis. So at that moment, with the clinical findings and with labs findings and the images as well, it was established as a clinical isolated transverse myelitis with high risk of conversion of multiple sclerosis. So of course, with all of her past medical history and family history, she had to be closely followed up for development of any further autoimmune diseases. So 2 treatment approaches were discussed at that moment. One was just observation after treatment with methylprednisolone, of course, and the other one was starting a disease-modifying therapy. The patient opted to continue with just observation, and a follow-up in 6 months was recommended. So here we have the scans that were shown in September 2020, 6 months after the initial presentation. Here we have the spinal T2 sagittal view, where again, the same hyperintense lesion is identified at the T10 level. And again, a new brain MRI was taken. And again, no evidence of inflammation, no evidence of tumor that somebody could tell at that moment.
And I see, Carlos, I see Dr. Rosenfeld here as well with us. At which point, because he's the one who send the patient to us. At which point was he already? He was already involved, in this case, at this point, or not yet?
Not yet. Here's before
not
getting
yet. I got you.
Oncology. That's correct.
Gotcha. All right. So we'll have him make some comments. And I don't know if there's anybody here from neuroradiology this morning. Did anybody join us?
Yes, Dr. Q. This is Amit Agarwal here.
Amit. So any thoughts so far about this? I mean, you see the lesion, especially in the spine. Any thoughts so far?
Sure. So younger patient, we see a short segment lesion just involving one vertebral level, and we'll think about demyelination as the first possibility. And when we say demyelination, the category is broad. It could be multiple sclerosis. It could be other causes for demyelination. we have this new entity or relatively new entity, which is NMOSD or neuromyelitis optica spectrum disorder, which could be due to anti-aquaporin 4 or MOG or myelin oligonucleotide complex. So, but the thing is that if it is a short segment lesion, the first thing we are thinking in our mind is demyelination rather than any cord tumor. No enhancement, short segment, no significant cord expansion. You should first evaluate for demyelination. So that's what I would have kept as the first differential here.
Beautiful. Thank you, Dr. Agarwal. That's wonderful. All righty, Carlitos, keep going. Steve is here with us. He joined us early. So at one point, we'll have him comment about when he got involved.
Perfect. Thank you, Dr. Arwell. So after that 1 year, at that moment, after those 6 months, again, a 1 year follow-up was recommended as her symptoms were stable. But at that 1 year follow-up, the patient presented with leg weakness, some complaints of urinary incontinence, memory problems, and night sweats as well. So at that moment, a new MRI was taken. Here, again, the thoracic MRI was stable. But here we see the actual T2 MRI, where we can actually see on the left side 2 lesions, a bigger one superiorly and a smaller one inferiorly, iso-intense with a parenchyma. Although it is making some mass effect in the brain, it doesn't appear to have any inflammation in the brain. And the lesions in the post-contrast images, there were contrast enhancing. As you can see right here, they appear to be coming from the bone itself, although it is in close relation to the dura. Dr. Agarwal, I don't know if you'd like to further comment on this.
Sure. So what we are seeing here is multiple lesions within the calvarium. This is the largest one, what you're showing in the left parietal bone, and it has destroyed the inner table of the calvarium. The outer table is also destroyed, but it's more prominent on the inner side. If you scroll the post-contrast images, Carlos, you can see how if you go down, you can faintly see how the dura is enhancing, but there's no intradural component. All the extraosseous component of this lesion is extradural, epidural. And whenever we see this thing, a large calvarial mass, we have the most common differential we have in our list is metastasis, which we would have kept here. If there are no other primaries, then we'll also think about multiple myeloma or plasmacytoma, that set of diseases. So at this point of time, we are thinking about metastasis or multiple myeloma.
Thank you, Dr. Arwell. And the patient underwent a PET scan. It was clean except for those 2 lesions, of course, which had increased uptake of FDG, as you can see right here in the bigger one and the smaller one here on the left side. And at that moment, the patient.
Carlitos,
Yes.
I was just going to ask, I assumed that these were lytic lesions, just listening also to Amit comment to this. I don't remember if we had a CT scan or not, but I would assume that these are lytic lesions, eating the bone away.
Yes, these are lytic lesions. And a good way to demarcate myeloma from metastasis will be a PET scan. And in normal cases, most of the myelomatous lesions are not hot on PET scan, but as the osteoblastic activity increases in myeloma, you can see increased uptake even on PET, as we see here. So in generally speaking, most of the metastases are hot on PET scan, and multiple myeloma lesions are not hot on PET scan, and that's a good way to demarcate. But sometimes there is more osteoblastic activities, even in myelomatous lesion, and they may appear hot. A good example as we see today.
I see Steve trying. Steve, you want to make a comment? I think that at this point, Dr. Rosenfeld, was asked to consult on the patient. Steve, you want to make some comments where we stand so far?
Oh, yeah. Sorry, yeah. I saw her after she saw neuroimmunology because there was concern of something other than demyelinating disease. And on exam, she had a fairly large, soft a palpable lesion over her posterior left frontal bone, as I recall, with pretty well demarcated margins that you could actually palpate. It was moderately tender. She had a prominent history of autoimmune disease, both in herself and in her family. And so what I was thinking about would be would have been some histiocytosis-like lesion first. Plasmacytoma was high up there, again, because of the lytic lesion in her calvarium. But she also had B-class symptoms, weight loss, night sweats, and so you'd worry about multiple myeloma and with a bony lesion as a presenting symptom.
Thank
And
you.
so at that point, I send her to you, Alfredo.
Thank you, Dr. Rosenfeld.
Thank you.
So yes, the patient was referred to the neurologic surgery department, and multiple treatment approaches were discussed, including observation and surgery. After further analysis of the case, it was recommended to proceed with a left-sided craniectomy with titanium mesh cranioplasty. The rationale for the procedure, of course, was to obtain tissue for diagnosis and to further plan treatment options for these patients after surgery, and of course to decrease the tumor burden in the area.
And I just want to say something that Dr. Rosenfeld very, very nicely mentioned right now, that it was fairly tender, and things that are tender, they're a little bit more concerning. So I remember when he told me and we talked, and he really felt that we needed to go after this, because at that point we didn't have a diagnosis. Observation, even though it's an alternative approach, we didn't think that it was a recommendation that we would give. So we recommended that we proceed to get a diagnosis, take it out. And ideal, take both of them out, the big one and the little one, which is what we have right here. So we get diagnosis and try to get a titanium mesh cranioplasty, because there was no way for us to really be able to get one of those 3D reconstructed bones, because I had no idea how much of the bone was going to be involved once I went in and we wanted to get clear margins. But that was a discussion that Dr. Rosenfeld and I had at this point. Anything else, Carlitos, in this area right here?
Nope, I think we're ready to proceed with the video.
That's it, so that way we can see what we found.
Yes. So here's a surgical video that was taken to the operative room, position supine with the head rotated to the right. As you can see, here's the incision plan in the parietal going to the temple area as well. The incision is made in a curvilinear fashion, and the dissection is carried down in planes. As you can see, the incision is further extended to turn the cutaneous flap, and the lesion was just right there, as you can see, in close relation to the subcutaneous tissue. A small portion of the tumor was taken to the frozen section, and a 15 blade was used to dissect the area. Dr. Kiano, you would like to further comment on this in this part?
I wanted to, everything that you said is perfect. I think that what we're trying to do right there is try to identify the plane and see whether or not the galea is involved. I think that, Amit mentioned that he didn't think that the dura was involved, or this, or the skin or the galea, but we have to double check, and we're trying to get those nice planes to try to just leave normal tissue behind. So that's what we did right there.
Yeah, and in the area you're trying to identify the smaller lesion, because it was located inferiorly, and right there with navigation, you clearly identify that the lesion was right there. The smaller one, which was difficult to see, and you mark it with purple here in this area. A burr hole is placed between these two lesions, and then the B1 foot plate is used to further shape the bone flap. As you can see, a good portion of the bone, of normal bone, is left behind between the tumor and the edge of the bone flap, just to make sure everything is taken out. And the bone flap is extended, of course, to the smaller lesion. Right there, the attention is turned to the interface between the tumor and the dura. As you can see, the lesion was not invading the dura, and this was softly dissected off. The dura, as you can see, came out nicely. And the lesion was removed in black. Right there. So it was a lesion coming directly from the bone and invading, of course, the parietal bones, you can see. So the dura was inspected for a second time just to make sure no lesion was left behind. And it was bipolar as well, as you can see. Here we can see the bone.
I wanted to.
Yeah.
I wanted to take those small little vessels on the dura just in case if there was microscopic disease that I couldn't see, you know, under the microscope. That's what we did right there. You know, just by polaring that, all those small little vessels, just to maximize, and also checking the bone at the same time, make sure that there's nothing left behind in the bone.
Here we can see the bone that was sent for permanent pathology section. There was irrigated and the cranioplasty with a titanium mesh was placed. And the wound was closed in layers. So here we had a gross total resection of those two lesions. Unfortunately, we don't have the actual pathology slides, but here's a representation of what we found. Here we can see multiple pleomorphic cells with increasing size of the nuclei and multiple nucleoli as well, which were consistent with plasma cells. Here we can see that the cells were positive with CD138, and here with gamma immunoglobulin as well, which was specific for plasma cell. So the final diagnosis was a plasmacytoma or a plasma cell neoplasm, kappa light chain restricted. And the bone flap was also analyzed, and it was shown, of course, to be invaded by this plasma cell. So the patient had an uneventful postoperative course, and she was discharged home on postoperative day 1. On postoperative day 3, she presented with an episode of transient aphasia at her home, and she was placed on Keppra. Currently, the patient is undergoing evaluation here at Mayo Clinic for multiple myeloma, and she just underwent a bone marrow biopsy a couple of days ago, and it appears that it will be most likely related to multiple myeloma, but we're still waiting for further evaluation. A few teaching points from this case, we saw, of course, that the lesion was consistent with a plasma cell neoplasm, which is an abnormal proliferation of clonal plasma cells. This lesion could be related to two different entities, one, of course, being multiple myeloma, and another one being just an isolated plasmacytoma without an underlying multiple myeloma. Most commonly, you see these lesions in multiple myeloma patients, and these are located at the skull most commonly, followed by meninges, nasopharynx, and brain parenchyma. A recent case series done at the Cleveland Clinic and the University of Colorado of 14 patients with plasmacytoma were found that 10 out of these 14 lesions were located to the skull, as we saw in this patient. And a recent systematic review at the NIH showed that, of course, autoimmune disorders are closely related and increase the risk of multiple myeloma and monoclonal gammopathy of undetermined significance. So we basically saw that representation in this patient. We saw how the patient had a strong past medical history and family history of autoimmune disorders and progressed 2% with one of those lesions at her 50s. So of course, it is important to closely follow up these patients just to see if they do not develop any further oncological issues. And that's it. I'll take any questions you might have. Thank you.
Steve, any comments from your side? Any surprises? Any teaching pearls that you can tell our residents, our fellows, from your perspective about this particular case?
Yeah, yeah. Well, you see a lytic lesion in the calvarium. Plasmacytoma should jump up towards the top of the list along with metastatic disease. In her case, there were, as I mentioned, as Carlos mentioned, there were systemic symptoms like night sweats, and generalized fatigue, which if this were a plasmacytoma, would increase the risk that this is going to evolve into, or already has evolved into, multiple myeloma. The other thing I meant that was in her history, I don't know if this was mentioned, is that on her skeletal survey, she had several areas of activity on her long bones, including her, I think it was her right femur. Again, that would push this from isolated plasmacytoma to either multiple parenchymal plasmacytomas or multiple myeloma. And I think putting this all together, the smell was more for multiple myeloma than plasmacytoma, but we obviously had to make a diagnosis and do it quickly. So that was the motivation for getting neurosurgery involved.
Thank you, Dr. Rosen. Thank you, Steve. That's a very, very good point. And I like the way that you talk about the symptomatology. You're already suspicious, of course, of the multiple myeloma. I see a comment by Dr. Miller, and David always has great insight. Go ahead, Dave. Dr. Miller, you want to comment in your chat comment?
Yeah, multiple myeloma patients very often get spinal involvement. They get compression fractures, either from the myeloma itself or from the associated treatments, often involving steroid and steroid-associated osteoporosis or radiation and radiation-associated osteoporosis. They respond very well to vertebroplasty. If we find lesions that we think have active plasma cells in them, we can also combine the vertebroplasty with radiofrequency ablation, which is also effective at local control. But it's one of those things that we find that the lesions are often very debilitating in these people, but they respond very well to the minimally invasive treatment.
Beautiful. Thank you, Dr. Miller. This is a very, very good point. So I suspect then for this particular patient of Dr. Rosenfeld, I think that we may see this patient, hopefully it'll do well over the months and years to come, but you have some other potential issues that will come up for which our colleagues are going to be called upon, like Dr. Miller, for some other potential procedures. I see Gabriel right here. Gabriel, did I see you? I see you, your hand. Go ahead, Gabriel, and then we'll go to Ala. Go ahead, Gabriel, please. Dr. Vargas from Bucaramanga, from Colombia. Go ahead.
Just a question for technical point on the final. Here, I sometimes with titanium mesh, sometimes the skin get stuck with that titanium mesh. What is your opinion? And I don't like to use right now because of many cases of that kind of finding. After some times, even years, the titanium mesh get stuck with the skin. So I, for these cases, with eventually not prepared cranioplasty, I prefer to use just bone cement and try to do something and attach with plates. I don't know what is your opinion on that.
Very, very good point from the technical aspect. So this is the way I've been thinking about it over the years. I was yesterday with Krishnan, Dr. Ravindran in the operating room, and we did a cutaneous flap in a patient, and the flap was literally maybe the skin was about 3 to 4 millimeters thick. You know, that patient that we just showed, their scalp was probably about 8 millimeters thick. So depending on that, so in that particular case, I was ready to leave with nothing actually potentially, because I don't know what kind of therapy they're gonna have. I'd rather put them in a helmet and then come back and potentially do a nice 3D reconstruction cranioplasty. If that patient would have the scalp of my patient yesterday, I do agree with you that when they get stuck. The second is, if the galea would have been invaded for me, I would have probably not, for sure, I wouldn't have put any mesh cranioplasty, leave it undone, come back at a later time with plastic surgery and do one of those 3D reconstructions where we put something back. You know, the defect was, you know, not gigantic and stuff like that. So I put them in a helmet. So that's sort of my way of thinking about that, you know, depending on the patient, depending what I find. But I had already talked to her about potentially not having anything right there and then coming back and doing a cranioplasty. But once I went in, I saw the galea was not invaded. She had a very thick scalp that you saw right there, very vascular, healthy. I said, okay, we can definitely put one of this. And even if there's a little bit of attachment, I don't think it's going to be a very good, much of a deal. I don't know for sure. We don't have prospective data to be able, but that's more or less the way I think technically about that. Good. I see Dr. Monteser. Ala, you know, you've probably done some of these cases. I see your hand raised. Go ahead, Ala.
Thank you. I'm just trying to connect the dots here in this case between the spinal lesion and the cranial lesion. Given the plasmacytoma, and considering that the lesion in the spine is a plasmacytoma, how common it is for a plasmacytoma to affect the cord and not affect the vertebral column? It's more common to have a vertebral column affection with kind of like some sort of compression on the cord. So I don't know how common it is to have a plasmacytoma focal intramedullary within the cord.
I think this gets back to the issue what her final diagnosis is. It is seen in multiple myeloma, and that's why one of the reasons that we wondered about whether this might be more than just an isolated plasmacytoma. And so, again, I think I suspect the bone marrow biopsy is going to show myeloma.
Beautiful. Apologies. No, sorry, I was just going to say my connection is a little bit unstable, so I lost, but I did hear some of the stuff, the question from Ala and the answer from Steve. So I think that makes a lot of sense. Very good. All righty. Well, that was a great case. We moved to a second case, similar importance. Let's see. Andrea, do you want to take it away? Diogo, is Andrea here?
I am reaching out to her, sir, to double check.
I reviewed the case with her yesterday. Beautiful case. If she's not here, you know, we can always reconvene and present it at a later time. Because I don't think I have seen her logging in this morning. Has she?
I thought I saw her earlier, and I reviewed the case as well yesterday.
Yeah.
I guess we could, you and I could do it, Dr. Q.
Rocky's excited about this case. You're hearing him in the background. We apologize. Give us a minute. Diogo's trying to get a hold of her because I thought that she was connected already. She might have dropped off.
Idiosyncrasies of the connected world.
Yes, that's true, Dave. Very true.
Lots of people can be there that can never be there before. However, suddenly people who are there are not there.
I know.
Do we have the video all loaded up in here, or like her slides? Are they already in here?
No, we do not, but I'm trying to get a hold of her.
Okay, all right. That is a vicious dog, Dr. Q.
I know. They're both of them. They're getting all excited.
So Dr. Q, if you have a minute, where's Mission Brain going next?
Oh, yes. So thank you for mentioning that. So obviously 2020, 2021, we couldn't travel anywhere, but we tried to give some help to some of the programs. We're sending some help to Haiti. We are planning in early 2022 to go, and the first trip is probably going to be to Mexico City somewhere in February, tentative, and then potentially do another 2 trips back to back in Guadalajara, Monterrey, Peru. We are planning to go ahead and have another trip to the Philippines. So I think those are going to be the trip next year. And I think that we're very eager right now. We have an extraordinarily active chapter in India, and I've been trying to go to India for a few years now. And we just had a very active group of doctors there that are doing an amazing job. So I think that would probably be the lineup, David, but I'm not quite sure because so far, you know, this pandemic is been quite unpredictable.
Yeah, it seems every time we think we're past something, you can make plans, it changes.
Yes, that's right. So, but maybe you can join us. How's that?
I would love to join you. I think it's wonderful work being done, and absolutely, if there's anything that we can contribute, we're happy to do from our end.
And I see Gabriel right here. He turned his camera. I promised him also that we were gonna go to Bucaramanga. So he just reminded me in a very subtle way by turning his camera on. Maybe we can
You always are very welcome here. You
Yes.
know that.
I know.
You are part of this university here, so
I know.
you don't need invitation.
I know. Maybe we can take David and he can do some endovascular cases with us. You know,
that would be good.
no.
That would be good.
I would
That would
love
be
to
great.
do that. I would love to join you.
Excellent, very good. Well, unfortunately, Andrea is not picking up the call, so let's do the following. I know that people. Go ahead.
We don't need. No, I said we don't need biplane. I can do it single plane. Whatever you
That's
got.
right.
You got a camera. We can help you.
I think Dr. Q also froze. We'll
Yes,
just give it a
I
few minutes.
did.
Oh, sorry, sir.
I did. No, I'm sorry. My connection is so unstable. It keep switching between two Wi-Fi. I literally have. I'm just going to show you right here in my corner in my house. Right there, I have two towers completely dedicated for my connections, and none of them are working. So I mean, I am paying for two different services, you know, to make this work because I do so many meetings and we've been having issues. So, good. Let's call the morning. We're gonna have to present this case. Unfortunately, the time is gonna be limited. This is a case of Dr. Substance. It's a beautiful case. I'm not quite sure. Hopefully, Andres okay, but let's save it for next week. All right, or the week. Actually,
we'll do
next
so.
week. Next week. Tell us what we have next week.
So
isn't
next
that
week we're gonna have the students that are rotating with us. They end their rotation, so they're
Gotcha.
gonna be presenting. And the week after, we're gonna have Dr. Hakim from Colombia.
Beautiful, beautiful.
those
So
are
that's
the
great.
next 2
So
weeks.
Gabriel, so let's make sure that Monday we advertise that in our poster,
Yeah.
so that way people know in the
Okay.
lecture series. So Gabriel, 2 weeks from now we're gonna have Fernando, and maybe one of these weeks we have your team right there also presenting a couple of your cases as you did before. I know you presented a couple of months ago, and then we're trying to rotate also from Mexico and anywhere else in the world. So, but that
In
would be great.
October, we're gonna have Mexico, sir.
Oh, great. Also, you're already lining them up. Good. All right. Very good. We apologize for the technical difficulties. I know Andrea was here and we reviewed both David and I. Beautiful case, but we better save it, Dave, to be honest with you. All right.
No worries. Sounds good.
All righty. Have a great day, everybody.
Thank you
Enjoy
very
the
much.
weekend. Stay safe.
Thank you.
Adios. Bye-bye.
Hasta luego.
Hasta
Gracias.
luego. Bye-bye. Gracias.